So somebody wanted to know about the different localizations of optic neuropathy, and we're only going to do the unilateral one for simplicity. The optic nerve actually has four pieces. It has an intraocular piece, which we call the optic disc or the papilla. It has an intraorbital piece. This is in the orbit. And then it has this canal piece, that's the optic canal, which is a bony canal, optic canal piece. And then the intracranial piece, which connects to the optic chiasm. So those are the four segments of the optic nerve. So you could have intraocular, intraorbital, intracanalicular, or intracranial optic neuropathy. It's important to differentiate these because the localization determines in part the imaging study. So I would say the number one imaging problem with not knowing what I just told you is you do an MRI, but you only did the head. If you do the MRI only of the head, you are only imaging the intracranial and the intracanalicular part. By far and away, this is the most common error for missing a tumor causing an optic neuropathy, because you need to have the orbit. So we would like to add the orbit. And if you watch those other MRI videos, you know that we want to have gadolinium contrast material and the suppression of the fat signal, fat set. So this is the imaging study of choice to image all four pieces of the optic nerve: MR, head and orbit, gadolinium, and fat suppression sequences. So how do we differentiate these things? Well, of course, if you have intraocular disease, the optic nerve is involved. We'd like to know if you have intraocular disease elsewhere in the eye. Anterior uveitis, intermediate uveitis, vitreous cells, retinal vasculitis, macular edema. Those are all going to be saying, well, this disc is swollen because of something in the eye. That's intraocular. You can have intraorbital. That's going to be ophthalmoplegia and ptosis, pupil involvement, because you have other things that live in the orbit, and the main orbital sign, proptosis. The eye will be bulgy. So if the lesion's in the orbit, we want to do a Hertel exophthalmometer and see if it's a bulgy eye. And in the canal, that's a very dangerous place for a lesion to be because it's a compartment syndrome. A very small lesion in the canal can cause bad vision because it can't go anywhere. And so now you can see why imaging the canal is super important. The other reason the canal is important in trauma. So even though the force is usually delivered at the forehead, like a bicyclist goes over their handlebars, the force is actually felt in the canal because the orbit's shaped like a cone, like this, like an ice cream cone. So the force is here, but they feel it in the canal. A little bit of edema in the canal causes big vision loss. So that one you need a CAT scan for it. So for most optic neuropathies, MR, but in traumatic optic neuropathy, CT, head, orbit, and canal. The intracranial is interesting because it's approaching the optic chiasm at that location. And so the fibers are trying to cross if they're nasal and are staying uncrossed if they're temporal. And what that means is lesions of the intracranial optic nerve can be associated with visual field defects that are now starting to respect the vertical meridian, as opposed to most of the optic neuropathy fields are going to respect the horizontal meridian because they're nerve fiber layer in distribution, and you can watch the nerve fiber layer video for that information. So if you have a lesion right here at the junction of the optic nerve and chiasm in the intracranial optic nerve, you'll get a monocular hemianopic field defect, either temporal or nasal, depending on whether the compression is nasal or temporal. And because this fiber is very close to the chiasm, you might get a field defect that's an optic neuropathy in one eye and a superior temporal field defect in the fellow eye because the nasal crossing fiber is trying to cross at that location. These are both junctional field defects. This one here, the monocular field defect, is called the junctional scotoma of Traquair. And this one here is just called the junctional scotoma. They're both junctional. So you need to know a little bit about how the optic neuropathies look and act differently: intraocular, intraorbital, intracanalicular, and intracranial. You need to know the imaging study of choice is MR, head, orbit, gadolinium plus contrast, and fat suppression, unless it's trauma, or you're looking for hyperostosis or calcification, or they can't have an MRI. That's CT, to look right there at that bone. And recognizing the intracranial field defects associated with junctional intracranial optic neuropathy, the junctional scotoma of Traquair, and the junctional scotoma.